So hello, my name is Charles. I'm currently an F1 doctor coming to the end of my foundation year, going into F2. And today I'm going to be talking to you about my first rotation was acute geriatrics.
I've been dreaming all my life. I've been dreaming all my life. I've been dreaming all my life. Now I'm trying to switch it up.
So the structure of this job was actually we'd meet up in the morning, we'd have a meeting with some of the nurses, with some of the physios, and we'd just talk about what the plan was for each and every patient. So we'll start off with the medical problems that they're facing and then talk about housing issues or other physio related issues that they had that they needed to happen. So from there on the ward, there'll be about 30 patients. They'll be split into 3 bays. And then of those 3 bays, usually there would be about 4 doctors sometimes on that ward. I would end up with about 6 to 7 patients that I would see. Since I was new on that ward, I would usually see the medically fit patients, so it wasn't too stressful. The kind of things that you would do is you'd go through the notes, see what jobs were done yesterday, any pending investigations that needed to be followed up, and you'd go through the observations, see how they're doing in terms of the last day, if they had any deteriorations. You'd look at the blood investigations. You'd go through it very systematically and very thorough, and then from there you would be able to examine them, see how the patient is doing, how they're progressing, if they've got a chest infection, is it clearing, is it worsening, does the chest sound crackly, have they had bloods recently, is that a job that needs to be added on, do I need to refer this patient for an investigation later on in the day. Usually the patients that are not medically well were reviewed by a consultant, and the consultant will do the examination and your job is to just document. For medically fit patients, you're allowed to see them on your own and actually take more of an active role in that process. Usually it would start from 9 and you should be done with ward round around 12. From 12 till 1 you start cracking on with some of the jobs, and then from 1 to 1:30 you could usually take a lunch break. On different days, for example Thursday or Tuesday, there will be teaching or for the ward where someone in the team would present a case. Throughout that week there's also other things you do, like the foundation teaching program, which you go on Thursday afternoons for my trust. Usually you finish your jobs around 4 p.m. and then you go on and ask other colleagues if they need any help. Usually on medicine on most days you'd finish on time. The different kinds of shift patterns you'd have: your normal day, which is 9 to 5, which you spend on your ward. Other days where you carry the on-call bleep, so you'd meet up with the cardiac arrest team in the morning around 8:45, 8:30. You get the cardiac arrest bleep with them, you go through a brief meeting of anything they're expecting you to do. If there's a cardiac arrest, so you're either cannulating or you're taking bloods, that sort of thing, and then you go back to your ward. Your bleep can go off anytime during the day. You have to leave what you're doing and go to where the cardiac arrest is. There'll be an F1, there could be a core trainee, and there's also going to be a reg, and then there'll be the cardiac arrest team that come as well. Other shift patterns you have is you'd have weekends where you're practically covering any ward or anything that needs picking up from 9 till 5, and then you're on call from 5 till 9. When you're on call from 5 to 9, you're covering the majority of medical wards on your own, and you can get a bleep from any of the wards asking you to do anything from going to see someone who's short of breath to prescribing fluids or prescribing medication. You know, in these jobs, it's sort of you're working closely with a med reg, so if you have a case that you examined, you've done your ATE assessment and you're not sure, this is the time you pick up the phone, you call the med reg. Equally, you can work the other way around. They can ask you to go and see someone if they're bombarded with people to see. Biggest challenge of this is you're doing the on-call shift and you're carrying the crash bleed. So you're juggling between seeing acutely unwell patient and also having to rush to cardiac arrest. This can be quite stressful. The final type of shift pattern you can have is a night shift, which usually starts from 9 till 9 p.m. Obviously it's busier in the first half of the night. In the middle of the night things quieten down, and in the morning there's not really much to do, so you can usually go and grab breakfast, especially in the last hour, and then you go to the handover room to hand over to the day team. Things that I enjoyed about acute medicine: there's loads of learning opportunities. The consultants are usually very good at teaching. It's very hands-on in terms of you're seeing loads of different conditions day in, day out. It's loads of learning opportunities. That's the greatest thing about it. Things that I hated about it is it's always stressful. The shift pattern would be like a normal day and random 2 on-call days on any days of the week that they wanted, so it was hard for you to take annual leave for a consecutive period of time because of how the on-calls were scheduled, especially where I work. It made it very difficult, and it was very stressful to begin with because I just came out from medical school, and getting used to the gist of things is very hard in the initial stages. It's not what you expect.
I've been dreaming all my life. I've been dreaming all my life. I've been dreaming all my life. Now I'm trying to switch it up.